Patient now in this story has had a recurrence after a relatively long interval. If you think about it, her first treatment for interval was only about 4 months, and now she's gone almost 7 months on that current regimen. Sometimes the way that patients respond to a particular therapy can also give you some insight into their biology. In this particular patient, she went on chemotherapy with bevacizumab and then went on to this bevacizumab kind of maintenance, and I assume it was because of toxicities that came with the chemotherapy. But she was able to maintain for a number of months, and now she has another, what looks like to be recurrence. Interestingly, she developed ascites again. So this brings up another really interesting aspect about the biology of the tumor. As I mentioned in the earlier segments, patients have oftentimes VEGF is one of the factors that seems to drive this ascites formation, and now this tumor is being blocked from that standpoint by the bevacizumab, but is still developing ascites. And this is a clinical situation which is tricky and difficult to treat. But having said that, we would essentially then look to other potential strategies that she's not seen in terms of the chemotherapies, and so there's a number of those out there. I mentioned them before as they're actually the chemotherapy backbones for the Aurelia trial. All the drugs that were listed there, including other drugs like gemcitabine, would certainly be options for therapy. And another question that comes up sometimes in this situation is whether or not we should use other combinations. And I think that that's a good question. We've done some randomized trials looking at drug combinations in patients who have platinum-resistant or refractory disease, and we've basically seen that the doublet therapy really hasn't panned out. But there is at least some idea that maybe the gemcitabine cisplatin or combination might have some activity. We've studied this in the GOG, and there's a number of reports in the global literature of this combination. I'd like to use that drug combination in this setting. If you think about it, she's not had a platinum for quite a period of time, almost a year now, and gemcitabine and cisplatin do have drug-drug synergy. And so there are some data in platinum-resistant patients who received both response rates and delay in progression with that combination, even though she would be considered a platinum-resistant or platinum-refractory type of patient. So that would be another option in terms of combination. A critical piece that I mentioned early on in this case history was that she was young with no family history. And I would say that the response of her tumor to the treatment would indicate that this particular tumor is not following the lines of a tumor type that actually is vulnerable to the machinery that normally fix this. We call that the homologous recombination machinery. So I would not consider her as somebody that would necessarily be a good candidate for, say, a PARP inhibitor. But I would say, as I did mention before, that somatic testing might be informative in a case like this. And the one gene I'm specifically referring to is the BRCA genes. We know that about 25% of patients will have an alteration either in the germline, which is the majority, or in the tumor itself would be the somatic mutation. It's about 7%. And in a patient like this at 38, we would have actually done germline testing at the diagnosis. That would have been standard of care, and we would expect that at least that data be available to us. But in this situation, even with that data known, it would be of value to at least check in the tumor to see if there was an alteration in the BRCA genes. And the reason I say that is that there are now essentially 2 drugs that are approved for treatment. In this particular patient, since she's only had 2 prior lines, the drug rucaparib would be the drug that she would be eligible for to receive if she had a somatic mutation in BRCA. I think that the issue about whether or not she is likely to respond to that is a completely different question. And as I mentioned, since her tumor is demonstrating that drugs like topotecan and platinum didn't really work all that well for her, that maybe this machinery is still intact and a PARP might not work. But it would be something to add to that list of potential options.